Myelopathy of undetermined significance, MGUS. The definition, fewer than 10% plasma cells and an M spike less than 3 grams per deciliter. The intermediate stage, smoldering multiple myeloma with 10% or more plasma cells and or an M spike greater than 3 grams per deciliter, and then multiple myeloma with an increase in plasma cells of 10% or greater, and most importantly, end organ damage. MGUS, as I mentioned a moment ago, has an M spike of less than 3 grams per deciliter, fewer than 10% plasma cells in the bone marrow if done, no evidence of other B-cell disorders, and most importantly, no end organ damage. This is a collection of 241 patients who had an M protein in the serum, but no evidence of multiple myeloma, Waldenstrom's macroglobulinemia, AL amyloidosis, or lymphoma that were collected at the Mayo Clinic from 1956 to 1970. These patients had a risk of progression to multiple myeloma or a related plasma cell disorder, 17% at 10 years, 34% at 20 years, and 39% at 25 years. Now, these numbers of progression look a little high, and they are, because electrophoresis was done mainly on filter paper for the majority of these patients. And as you know, this is not as sensitive as agarose gel that we use today. The size of the M spike was about a half gram higher than in the series that I'm going to show you in a moment. This is a collection of 1,384 patients from the 11 counties in southeastern Minnesota. Jan Waldenstrom did not believe that patients who had no progression to myeloma at the end of 3 years had a stable disease and should be called benign monoclonal gammopathy. Now, we weren't so certain either of our initial data because these patients were collected from individuals who had come from all over the United States and Canada, as well as a number from Europe. So we decided to look at those patients in Olmsted County and the 10 counties surrounding it. In this group of 1,384 patients, the risk of progression was 10% at 10 years, 21% at 20 years, and 26% at 25 years. I want to emphasize that in the patient with MGUS, that on day one, the average age, or median age, I should say, is 72 years. And if you follow a 72-year-old person for 20 or 25 years, there are a lot of other things that happen to that patient or can happen to that individual that are unrelated to the plasma cell disorder. So when we look at competing risks At 10 years, the risk of developing a plasma cell proliferative disorder is 6%, whereas the risk of death from a cardiac source or from a cerebrovascular reaction or a malignancy unrelated to plasma cells is considerably higher. And one sees at 20 years 10% progression to myeloma compared to a 72% death rate from the other unrelated causes. This is an important point to keep in mind when visiting the patient. In the initial study, we made the point that the risk of progression was 25% over a 25-year follow-up. This obviously made for a lot of nervous and apprehensive patients. And so I finally learned that it was much better to discuss the situation with a patient, telling the anxiety-ridden individual that they had a 99% chance of having no trouble with their monoclonal gammopathy during the next year. This sounds much better than a 25% progression over 25 years, both of which are correct. This is shows us the prevalence of MGUS in Olmsted County. We see in the 50s 1.7% of the population. In the 60s, it's up to 3%, 4.5% in the 70s. And in fact, for those patients who are older than 70 years, it is a little more than 5%. This shows the progression, the red in males and the green in females, and you can see that the rate in females follows that in males, but about a decade behind, suggesting perhaps that women age less than we do, than men do. My colleague Vincent Rajkumar looked at this cohort, was able to, we were able to find sera from 1,048 of these 1,384 patients. And he looked at risk factors consisting of an M protein less than 1.5 gram per deciliter, the presence of IgG at a normal free light chain ratio. And those patients who had no abnormal risk factors had an absolute progression rate at 20 years of 5%, and if one took into consideration the competing death, only 2% of these patients had progression to myeloma or a related disorder at 20 years. If one of the three risk factors were present, the risk was 21% absolute, and if all three risk factors were abnormal, that is an M spike greater than 1.5 grams per deciliter, IgA or IgM, or an abnormal free light chain ratio, the risk was 58% and 27% if one took into consideration the competing risks. we feel that if there are no risk factors present, that routine skeletal x-rays and a bone marrow aspirate and biopsy are not necessary. However, it is important to follow these patients up at 4 to 6 months because one may have inadvertently tumbled onto a patient with a monoclonal gammopathy that is in the process of progressing. And at 6 months, the CBC should be repeated, calcium and creatinine levels determined, serum protein electrophoresis performed, urine electrophoresis if an M spike were found in the urine initially, a serum free light chain assay, and quantitation of the immunoglobulins. Now, patients with smoldering multiple myeloma, by our definition, have an M spike of 3 grams per deciliter or greater, and or a bone marrow plasma cell content of 10% or greater, and no end organ damage. Now, the definition of smoldering multiple myeloma, I think, needs to be looked at carefully, because there are some patients who are at high risk for progressing. Here we see the progression rate in 276 patients with smoldering multiple myeloma. And the most impressive thing is the fact that 51% of the patients progress within the first 5 years of recognition. In other words, 10% per year. However, after 5 years, the risk falls to approximately 3% per year, and after 10 years, the risk falls to 1 to 2% per year, suggesting that patients that are included in this definition actually may well have multiple myeloma or incipient myeloma, and treatment needs to be considered, whereas those patients who go for more than 10 years probably belong in the MGUS group. However, it's not possible to determine who is who at the time of recognition of the monoclonal gammopathy. We have looked at these patients, and if patients with smoldering multiple myeloma have a bone marrow that contains 60% or more plasma cells at the time of recognition, we find that there is a 90% chance of those patients developing symptomatic multiple myeloma within the first 2 years, and we feel that those patients should be treated as active multiple myeloma. If the free light chain ratio is greater than 100, there is an 80% risk of progression within 2 years, and those patients should also be treated as multiple myeloma. If the patient on MRI has more than one focal lesion, the risk is approximately 70%, and we feel that those patients do merit therapy for their disease. For those patients who have an evolving type of smoldering multiple myeloma. In other words, patients who have a slowly increasing M spike in the serum, the risk is, in this series, 65%, and we feel that one should consider preventive therapy or trials, comparing therapy with a randomized group who are not treated. The presence of an abnormal plasma cell immunophenotype, 50% progression at 2 years, patients with smoldering myeloma with a translocation of 414 or a deletion of 17p, the risk is increased to about 50%. And those patients who have an initial M spike of 3 grams per deciliter and a bone marrow that contains 10% or more plasma cells, the risk is about 50%. Patients with a light chain ratio of greater than 8 but less than 100, a 40% risk, and we feel that those patients should also be considered to have a clinical trial. Those patients who have no high-risk factors account for 10 to 20% of the total and should be observed or possibly placed on clinical trials. The field is evolving, and one needs to follow these patients carefully and to attempt to sort out those individuals who are at a higher risk of progression, and then placing them in prospective randomized trials to determine if reduction in the M protein does indeed delay the onset of symptomatic multiple myeloma. Thank you for your attention.